going to talk now about sexuality after prostate cancer. So I would like to invite Dr. Bruno Nascimento. Dr. Bruno Nascimento is a physician, a surgeon, and a urologist trained at the Memorial Sloan Kettering Cancer Center in New York. His work and studies focus on all aspects of male sexual health and sexual rehabilitation of cancer patients. And Dr. Nascimento is also a member of the International Society of Sexual Medicine, and there he works, he's a member of the Communication Committee, and he's also the Vice Chair of the Young Researchers Committee. But Bruno Nascimento is also the Secretary General of the Brazilian Association for Studies of Sexual Medicine and Sexual Health. So, Bruno, we're happy to invite you. Everything is fine. Go ahead.
Good, great. So first, I would like to thank a lot ISSWSH for this invitation and compliment for this initiative. I would love to have more opportunity to live together side by side with Ariel. Hearing all the stories is very clear how impactful he was in good times and working times and all of times. This is a small honor post that we did in the Brazilian Association to honor him. And in English, it reads that there's no farewells for those who will always stay in our hearts. And I'm pretty sure that an event like this one, it's the materialization of his good work and his enthusiastic work in the sexual medicine field. So I'm very honored to be here today. So thank you very much for that. I have no disclosures for this presentation, and I was asked to speak a little bit on sexuality after prostate cancer treatment. And first, I would like to explain a little bit on why do we care that much for prostate cancer specifically? Why don't we speak that much about other forms of treatment, or at least that prostate cancer is the one that we speak most? And this is part of the reason. Prostate cancer is the second most common cause of cancers diagnosed in men, after lung cancer, if you exclude non-melanoma skin cancer. But a second part of this answer is this, which are great news actually, and says this table shows us that with treatment improvement, the life expectancy, the survival rates reached great numbers. And after 2010, the 5-year survival rates in the United States was greater than 98%. And we have also 10-year survival rates very close to that. As a result, we know that there is building up the number of men who are diagnosed, treated, and are now living in the post-treatment phase. We had more than 3 million into 2016, and we expect to have only in the US over 4.5 million of men living in such conditions. So that's why prostate cancer is important and why sexuality is something that important as well. And the reason for that is mostly because the 3 cornerstones of treatment for prostate cancers are radical prostatectomy, radiotherapy, and androgen deprivation therapy. So it's very difficult to imagine one of those more than 3 million men living in after prostate cancer who were not treated in one of those modalities. And they all have very different indications and sexual dysfunction profiles, but they all, for sure, are very related to those different forms of sexual dysfunction, including penile deformities with penile length loss and penile curvature, erectile dysfunction, sexual desire and mental health issues with hypoactive sexual disorders, depression, anxiety, frustration with their sexual life, ejaculation and orgasmic dysfunctions with decreased ejaculation or anejaculation, climacturia, which is losing urine during climax, decreased orgasm intensity or losing the ability to reach orgasm whatsoever, or painful orgasms. They all, of course, go through difficult times with changes in the sexual intimacy and satisfaction and relationship dynamics. So all those treatments are somehow able to give those dysfunctions. And it's not only something that they may cause, it's something that they usually cause and in great proportion. So for all the 3 mainstays treatment, hormonal therapy, radiotherapy, and radical prostatectomy, you can see that the incidence of dysfunctions are very high. This came from a Scandinavian study with almost 2 men included in a subjective questionnaire. But if you see the numbers, it's around 80, 75 to even 90% of prevalence for sexual dysfunction after all those 3 treatments. So it's very significant, it's diverse and impactful for sexual life, the whole prostate cancer treatment. But of course, to stay in my 15 minutes, I wouldn't be able to give a very comprehensive review of all of them. So I will focus my presentation on speaking on radical prostatectomy, post-radical prostatectomy sexuality, especially treating erectile dysfunction, which is probably the single most questioned by patients sexual dysfunction when going for a surgery like this one. So the ED rates reported in the literature vary greatly from 12 to 96%, and this probably translates different means to measure ED, different populations that were studied, different disease severity and surgeonability and things like that. But if I need to say a number which most likely represents the reality, I think 60%, around 60, 55 to 60% coming from meta-analysis are a proportion that truly suffers with ED post-op. And why does that happen? There are, of course, several reasons for that, but there are 2 main causes that I would like to go a little bit deeper because they also guide us through the treatment and to the restoring erectile function for those patients. And first is the neural trauma, which can be a full damage, or a neuropraxia, which is a temporary loss of neuronal function after smaller damage. And second, the corporal smooth muscle alteration. There are damages to the smooth muscle inside the penis. I will speak a little bit shortly. So as I know I'm not being watched only by urologists, this is an anatomic picture showing the path that the cavernous nerves go in the pelvis. So it's very clear that it's very intimately related to the prostate and the seminal vesicles, which are removed in that surgery. And from a different perspective, we can see that the nerves almost go around the prostate. So it's really something that it's impossible. The prostate is impossible to be taken from where it is without at least touching the nerves. And sometimes you have to remove the nerves, but at least you will have to move the nerves away to remove the prostate. And second, the corporal smooth muscle alteration. This is an Italian study with almost 20 patients where they did a penile biopsy before surgery, 2 months after surgery, and 1 year after surgery. And they were able to show an increased content in collagen and a decreased elastin content, showing that those smooth muscle structures were being substituted for scarring tissue. This was also already present at 2 months, but was much worse after 1 year. And the problem for that is that in this diagram, we can see that the big difference between the flaccid and the erect penis is smooth muscle relaxation. So while in the flaccid penis you don't have relaxation, all the blood that comes in goes out of the erectile chamber using this subtunical veins. In the erect penis, after a neurological trigger for smooth muscle relaxation, the blood gets trapped inside the chamber because the subtunical space is compressed by the dilated smooth muscle. So if you decrease the relaxation ability, substituting the smooth muscle for a scare, you will alter the veno-occlusive system and you're much more likely to have long-term or even refractory erectile dysfunction. So those are the main causes, I would say like that, but that will guide us through therapy. But what can we do? How can we manage those patients? So first, patient and partner education for sure. This is something that we don't speak that much, but if patients and partners heard very optimistic numbers about ED post-op, and they are expecting immediately good results or amazing first experience, they are very likely to feel demoralized, frustrated, and don't feel encouraged to a second attempt, a second line therapy, and things like that. So preemptive and realistic information really should be provided for all couples. Also, we must remember that what may be obvious for us is not obvious for them. So there are some patients that don't know they can reach orgasm without erections because that's not the way they usually function throughout the whole life. And there's no harm in sexual intimacy because some urologists also ask patients to stay away from sexual encounters for longer periods, even 3 months, 5 months. I've heard a lot of things like that. So that's an important consideration to be done. And second, about medical therapy itself, it really depends on the time frame after the prostatectomy, because in the first 18 to 24 months, you know that some of the worst or some of the bad neuronal function that the patient is presenting may be temporary. So you can still be under a neuropraxia, which will, with time, improve the function and recover better quality erection. So in this initial time, you must understand that this is temporary and be aggressive in the manage to restore erection. So restoring erections early will restore the possibility to intercourse, doing sexual encounters, and this is most likely very desired by the couple. And you can use the common tools, PD5 inhibitors, usually big dose, large doses, intracavernous injections, vacuum therapy, and penile implants are not usually recommended in this time frame, exactly because there's still improvement expected. Also, with improvement, patients usually downgrade from treatment, either needing lower dose PD5 inhibitors or moving away from intracavernous injections and becoming pill respondent with time. Penile rehabilitation is a very complex concept that I won't go deep in details, but it has 3 pillars. First, to improve cavernosal oxygenation and endothelial protection to prevent late-term damage in the smooth muscle, as we show with scar. So there are some debate if there is one specific protocol able to reach better chance of unassisted erectile functions over time, but mostly rehabilitation is usually a big area, very similar to treat aggressively ED since the beginning, and there's not much of a downside on restoring erection early. And after 2 years, we must understand that if the nerve didn't recover, it's actually a full damage and it won't be recovered, so we must treat the patient as a permanent damage and use all current ED therapies, and penile implants are more considered after this time point. I would love to have time to speak a little bit about sexual dysfunction, other sexual dysfunction after RP, as an ejaculation, orgasmic dysfunction, and climacturia. I won't do that because of the time, of course, but just as a small warning, I know that this is a very neglected sexual dysfunction. And so we must, as urologists, as practitioners, to at least guarantee that the patient know that this can happen and that this is not harmful, that this tends to improve, and that there are therapy for that. So please communicate to the patients, and if they communicate to you, we must offer all the therapies that there are. I know that my time is probably going over, so I would like just to use this image to say that's very common in the patient counseling and couple counseling, to say that we know that they are going to very probably to such of a stormy sea in terms of sexuality after surgery, but we kind of know the path. We know that what can happen and help them through these difficult times, and hopefully there are more calm waters ahead of them, so they should feel encouraged to go over and seek treatment. Thank you very much.